In this capture, we're going to take a look at pneumonia and COPD, as well as some other more serious respiratory disorders. As a precursor to pneumonia, I just want to make mention of atelectasis. You've heard this term before. We see this very commonly in patients who are postoperative and those who just are immobile, not moving around. And atelectasis is the closure or the collapse of the alveoli. So thinking about preventative strategies, early mobilization, getting them up, sitting in the chair, getting them up, walking, incentive spirometry, coughing and deep breathing. Symptoms that you'll see in relation to atelectasis, they will have increasing dyspnea, development of cough, perhaps productive with sputum. As it progresses, you might see the heart rate go up, the respiratory rate go up. They might be developing pleural pain. So when they're breathing, they might develop some pain when taking deep breaths. And if large areas of the lung are affected, they can actually develop what we call central cyanosis. So they start showing, that kind of bluish discoloration. Chest x-ray can actually show atelectasis before symptoms appear. So by the time they start showing symptoms, it's been going on for a little bit. And eventually their O2 sat starts to drop. So it's really important as nurses that we watch out for this. We really look at preventative strategies because we don't want it to occur, because atelectasis then can lead to the development of pneumonia. Speaking of pneumonia, this is an inflammatory process. It's generally triggered by infectious organisms, either bacteria, viral, fungus, or by aspiration. Okay, so that inflammatory process is going to result in edema. Those white blood cells are going to migrate to that area. They're going to start, the phagocytes are going to start trying to digest the bacteria. Basically, this creates an exudate, and then that exudate fills the alveoli. Well, where the exudate is, air can't really get through, so then you have a problem with gas exchange. So with pneumonia, you have an issue both with ventilation and diffusion. So ventilation, because of the edema in the mucus and the secretions that block the airway, the diffusion is impaired because of this inflammatory reaction and fluid in the alveoli. Okay, so again, any type of respiratory thing, we always want to focus on prevention. And you see I have it bolded and in red. Hand hygiene. Wash your flippin' hands and don't touch your face. There's also some vaccinations to try to help prevent pneumonia. I had mentioned these earlier, the Prevnar 13, Prevnar 23, also the influenza vaccine, because flu patients that end up dying, it's usually not from the flu, it's because of a secondary bacterial pneumonia. So trying to prevent the flu, that will try to, help them from being predisposed to this pneumonia. So I mentioned before causative factors: bacterial, viral, fungal, aspiration. There's also different classifications of pneumonia. There's community acquired, which this is what you see just out in the community. We have hospital acquired or hospital associated, healthcare associated, and this is the development of a pneumonia within, I think it's beyond like 48 hours of hospitalization. So it's a problem that developed while they were in the facility. And then we have ventilator-associated pneumonia, or VAP. We know that patients on ventilators are at very high risk for pneumonia. And there's actually an entire VAP protocol, a prevention protocol in relation to turning, repositioning patients, mouth care with chlorhexidine, just some different things that they do with your ventilator patients specifically to try to prevent VAP. Complications of pneumonia, they can become septic, where we now have the organism in their blood, and that can result in septic shock. You can also have what we call ARDS, which is acute respiratory distress syndrome, and that can lead to respiratory failure. Risk factors for pneumonia, your underlying respiratory conditions. So somebody who has the flu, somebody who has asthma, COPD, cystic fibrosis, smokers. Okay, smokers are at huge risk because the smoke itself not only affects the recoil and the elasticity of the lungs, but it actually affects the cilia and the protective mechanisms that you have in the respiratory tract. And infectious agents are more likely to get down into the lungs and cause a problem because I don't have that cilia working to try to get that out, get it up so your patient can cough it out, expectorate it out. Other chronic conditions such as diabetes, heart failure, renal disease, those are going to put somebody at risk for pneumonia. CVA is up there as a huge risk factor, particularly for aspiration pneumonia, because if you have a problem with your gag and swallow reflex, that protective reflex is gone, and now they can aspirate food or fluid, and that's going to create a breeding ground for infection. Certainly, if anyone is immunosuppressed, this could be disease-based, things like leukemia, HIV, AIDS, lupus, any type of autoimmune disease, as well as medication related. So somebody who's on long-term corticosteroids, somebody who's on long-term immunosuppressants, they're going to be at higher risk for pneumonia. And of course, alcohol and drug use as well are increased risk factors for pneumonia. So clinical manifestations are going to vary depending on the type of pneumonia, on the organism that's actually causing the problem, and whether or not the patient has any underlying disease. For somebody who's healthy, a mild case of pneumonia is probably not a big deal. Yeah, we'll be miserable, we'll be sick, we'll get over it, it'll be all right. Somebody who's already has lung compromise, it literally can take them to the edge of death's door. So it can be something really, really serious. So manifestations that you might see: chills and fever, flushing and diaphoresis. They may have pleuritic chest pain, where when they take a deep breath, it hurts. Their respiratory rate's probably going to be up. They may have shortness of air at rest. They will most likely have dyspnea on exertion. They may have orthopnea, where they're not able to lie flat. They have to be sitting up. One of the questions we always like to ask patients, if they have trouble breathing when they're laying down, how many pillows do they sleep on? How far elevated do they need to be? Your COPD patients, even though we're talking about pneumonia right now, your COPD patients will often, towards the end, sleep in a recliner chair versus actually sleeping in a bed. Other clinical manifestations of pneumonia: headache, low-grade fever, again, that achiness, pharyngitis, the sore throat. I have confusion up there, and I have a star next to that because I really want you to highlight that, because a lot of times in older adults, that may be the only symptom that they present with. Confusion, and then when we check their O2 set, it'll be low. Now that confusion, that could be the very first sign in our older adults, but that's also a very common sign in older adults of UTI. So just something to kind of keep in mind and tie in Unit 2, that when you have an older adult presenting with confusion, get your vital signs, get your O2 sat, because the top two differential diagnoses are going to be pneumonia and UTI. Other clinical manifestations: crackles and wheezes. Also decreased O2 saturation. They might have a cough. A lot of times they do. Typically it's a moist cough. Maybe they're producing sputum that they're able to cough up. Maybe they're not. The color of the sputum, the amount of the sputum can really vary. Diagnostic-wise, we're going to do a CBC, which will show elevated white count or neutrophils, usually. We'll want to look at their electrolytes just to evaluate their hydration status. They may also, excuse me, they may also run a round of ABGs. Again, just looking for hypoxemia. Do we have low levels of oxygen in the blood? Blood cultures will identify the presence or absence of the bacteria in the blood. So that's very helpful. It is important to understand that your patient can have pneumonia without having positive blood cultures. On the sputum, we definitely want to get a sputum sample so we can do a culture and sensitivity. Now, your sample can be one that's expectorated. Um, Usually, you're going to get your best sputum samples in the morning. Um, have them take some really good deep breaths and do a nice deep cough. We're not looking for spit, we're looking for sputum. So we're hacking up a loogie, okay? If they can't expectorate it, we can also get specimens through suctioning. We just use a special specimen trap on the suction catheter in order to get that. If at all possible, you want to get the specimen before starting antibiotics. Now, that being said, that's kind of a classic NCLEX thing. We always get the specimen before we're starting the antibiotics. So that's NCLEX. Real world, if your patient does not have a cough, or if it's a dry cough, there's no sputum, but they're showing signs of respiratory compromise, we are not going to wait to get that specimen before we start antibiotics and start treating them. Because if we did, they would die. Okay, they would be dead before we even potentially get that specimen. So, but as a rule of thumb, if possible, if it's an option, you want to get the specimen before you start the antibiotics. We will also use a chest X-ray, which will show pneumonia either as an infiltrate or an area of consolidation. So for patients with pneumonia, we definitely want to position them upright, okay? It's going to make it easier for them to breathe. It allows for greater lung expansion. Regarding with coughing, we want to encourage them to cough. We want to encourage them to expectorate those secretions. If they can't, we may need to suction them. So again, deep breathing instead of spirometry. Oxygen therapy. Again, a lot of times that's managed by respiratory therapy, but as the RN, you still need to do your focused respiratory assessment. You still need to manage their oxygen, make sure it's going at the correct flow rate. You also want to monitor for skin breakdown. With your oxygen delivery devices, whether it's a nasal cannula, whether it's a mask, they're going to be at risk for skin breakdown, particularly on their ears, the nose, and the mouth and chin area if they have a mask. Okay, so you really want to pay attention to that. Balancing activity and rest, as we talked about in a previous capture, hydration, nutrition. We may need to consult the dietitian in here and get them on board as part of the multidisciplinary team. Certainly smoking cessation. Usually that's not so much of an issue while they're in the hospital because one, they feel like crap, and two, they can't really smoke in the hospital. Some may try, but they're not supposed to. But this really is a time where we might want to collaborate with the provider to get a nicotine patch. Let's get them over those first couple days of withdrawal and set them up with success with the resources to continue with smoking cessation. Reassurance and therapeutic communication is going to be very important because the reality is your pneumonia patients can't breathe. And breathing is compatible with life. And when you have somebody who's short of breath, they can't get enough oxygen, that is very anxiety provoking. So patients are going to take their cue from you. They're going to take their cues from the nurses and the healthcare workers around them. So if you're panicky, they're going to be panicky. It's going to make their anxiety worse. It's going to make their shortness of breath worse. So just kind of keep that in mind. Medications. Again, if they're hospitalized with a pneumonia, without the specimen, we don't know whether it's bacterial or viral. And even if we have a specimen, it's going to take 48 hours at a minimum to grow out the bacteria. We don't have time to wait because if it does turn out to be bacterial and we don't start treatment for 2 to 3 days, we've lost that treatment time and they're more likely to have a negative outcome. So if it gets to the point where somebody is hospitalized with pneumonia, they are going to be on antibiotics. Even if it turns out to be viral, we cannot take that chance. You look at the benefit versus the risk to the patient. We will use bronchodilators to help open up those airways. They may or may not use glucocorticosteroids. This is mainly to reduce inflammation. But again, it also suppresses the immune system. So, as part of this, we're giving antibiotics, but we also want to basically support the patient while their own immune system helps fight this disease. So it depends on the provider. Sometimes they'll order the corticosteroids, sometimes they won't. Expectorants and antitussives, you gotta have to balance those out a little bit, because expectorants are to help promote the cough, to help promote the expectoration of those secretions, which is a good thing because I don't want the secretions in the airway. But the problem is, if you have a patient who's coughing and coughing and coughing and coughing and coughing, and they're just not getting any rest, I mean, it is just persistent. If you look over in the other column, we have balance, activity, and rest. Okay, so there may be times that an antitussive is appropriate for this patient just simply because they need to get the rest. They need to balance that activity and rest. So a lot of times you'll see expectorants and antitussives used. The idea is to try to use expectorants during the day, really kind of promote that, and then use antitussives to try to give them a period where they can rest, and kind of, regain that energy. Now you have to watch, because if they're on an antitussive and they have a lot of secretions, we worry about airway. So you kind of really have to balance that out. I have pulmonary rehab on there because this kind of, just like we have cardiac rehab, it's all about being able to gain their strength and gain their endurance again after a serious respiratory infection. Not all patients require pulmonary rehab. Usually those with some underlying respiratory disorders, COPD, asthma, might require that pulmonary rehab for them to be able to really build up that endurance again, and be able to get back to their activities without becoming significantly short of breath. I want to touch on PE here for a second. Later on in Unit 5, we're going to talk about DVT, which is obviously directly associated with PE, because a lot of times the PE is going to come from the DVT. But I just wanted to include it here since we're talking about respiratory. But essentially, an embolus is a clot. So with a PE, there is a blockage of either the main pulmonary artery or a branch off of the pulmonary artery. And that blockage is going to result in either decreased or completely absent blood flow. If there's not blood flowing there, we got two things. One, okay, the areas in which are fed by that, those cells themselves are not getting enough oxygen. And two, the blood not flowing through there, there's no gas exchange taking place there, so there's going to be inadequate levels of oxygen in the blood that is circulating. Okay? All of this is going to increase the pressure in the lungs. It's going to increase the right ventricular workload. So you have a ventilation perfusion imbalance. It can then go into ventricular failure, right ventricular failure, and shock. Okay, so the biggest thing to understand with PE is immobility is your biggest risk factor, and that ties into DVT. So really getting your patient mobilized, keeping them hydrated is very important. If they're in a situation where they have decreased mobility, such as hospitalization, we will often use what we call VTE prophylaxis, venous thromboembolism prophylaxis. So things like TEDs, SCUDs, anticoagulants, enoxaparin, that sort of thing. Dyspnea is the most common symptom of PE, and treatment is really about supporting the respiratory system, cardiovascular support. If it is a major PE, we may be able to use thrombolytic therapy. We'll talk a little bit more about thrombolytic therapy in future captures, but when you think about thrombolytics, they're basically a clot buster, a clot dissolver. So kind of think about it as Pac-Man, okay, except instead of eating his little pills, he's eating away at the clot. In severe cases, they may actually need to do surgery, either through angiography or actually open surgery to remove the clot and reestablish that blood flow. Cystic fibrosis, I'm just going to touch on this a little bit. This used to be a disease that we really considered it a pediatric disease, because the reality is these patients generally did not live into adulthood. With our increasing technology, our improvements in healthcare, you are now seeing adult CF patients. So it is something that I wanted to touch on because you are seeing it out there in practice. So CF is a genetic disorder. It's autosomal recessive. Basically, both parents need to be a carrier, and the baby has a 1 in 4 shot if both parents are a carrier of having actually disease CF. They actually have other shots of being carriers, but for the actual disease, it's usually a 1 in 4. So basically, this genetic mutation, it affects chloride transport. So ultimately, this creates thick, viscous secretions throughout the body. Pancreas, lungs, liver, intestines, reproductive tract. So you have these thick, tenacious secretions. While all of those systems are important, obviously the one that has the potential to kill them first is going to be respiratory. So because of these thick, viscous secretions, they are at much higher risk for contracting respiratory infections. And because of the thick, viscous secretions, they generally are at higher risk for airway obstruction. So other big issues, malnutrition becomes a problem because, again, they have the thick secretions in the GI tract, so things aren't digested as well and nutrients aren't absorbed as well. And because of the reproductive tract items, this generally causes infertility. Asthma, and I want to talk a little bit about asthma before we get to COPD. Okay, asthma is chronic, but the key thing is reversible inflammation of the airways. Okay, so what happens is the airways get hyperresponsive, it increases mucosal edema, and you have increased mucus production. Now, even though it is reversible, I want you to understand that with recurrent asthma attacks, recurrent asthma exacerbations, it is resulting in long-term damage. So even though the initial attack is reversible, long-term this is creating chronic damage. Allergy is the strongest predisposing factor to asthma, and symptoms that you'll commonly see in the patient is they'll have a cough, they'll have chest tightness and wheezing. They will be dyspneic, they'll get diaphoretic. Again, their body is trying to get adequate oxygen into the lungs. Their heart rate will go up in an effort of compensation, trying to pump the oxygen that's already there. They will develop hypoxemia, so low levels of oxygen in the blood. And if unchecked, they will get cyanotic. Very important to understand with asthma, when we talk about the management of asthma, you have rescue and you have maintenance. This is also going to be a concept when we talk about regular COPD, and we talk about long-term management of COPD and management of acute symptoms, acute exacerbations. But for asthma, quick relief, they're having shortness of breath right now, it's tight right now, I can't breathe right now. We're using quick relief rescue medications. So our beta-2 adrenergic agonists are anticholinergics. So this is where you're going to see your albuterol, your ipratropium, your duoneb. Okay, we're trying to open up those airways right now. For long-term treatment, maintenance meds, we want to keep those airways open all the time. We don't want flare-ups. Here is where we use inhaled corticosteroids. We use long-acting beta-2 adrenergic agonists, and we'll use things like leukotriene modifiers. Okay, these are all to maintain respiratory functions to really prevent asthma attacks. Okay, your quick relief, your rescue meds, those are the things we're going to give urgently when your patient is having acute shortness of air. So with asthma, in relation to patient teaching, very important to help them identify triggers and encourage them to try to avoid triggers. If you know that every time you go to visit Aunt Sally and she has this dog and every time it sets you off in an asthma attack or respiratory difficulty, well, then either don't go visit Aunt Sally or ask Aunt Sally when you come to visit if Fido can be locked up. Okay? So they need to identify and avoid triggers. Sometimes it's food. Sometimes it's environmental things. It could be outdoor environmental things. But identifying and avoiding triggers is going to be really important. Again, because we want to prevent those acute exacerbations, because repeated acute exacerbations are going to cause long-term damage. Peak flow monitoring is also very important. And you'll see this coincide with the asthma action plan to the right side of your screen. Peak flow is basically looking at how much air they can exhale. So they use this device and they're going to exhale as hard as they can to see what their reading is. They do this 3 times and they generally take the average of the 3 readings. Okay, and depending on what that is, that will put them in a green zone, a yellow zone, or a red zone. Okay, so having an action plan is going to be very important for them to monitor their asthma and respond to their asthma early before we get to the point that we are in the red zone. Okay, I have some pictures up there, meter dose inhaler versus a DPI. I don't have a picture of a nebulizer up there. You need to understand the difference between these two. Meter dose inhalers are like a liquid that when we push it out, it's going to aerosolize. Okay, your DPIs are dry powder inhalers. So these are a dry powder that gets inhaled into the respiratory tract. Okay, and then of course you have your nebulizer, which is your handheld nebulizer where we're attaching it to air and it's actually, vaporizing and they're breathing it in. The reason I like to point this out, particularly when you're doing clinical prep, you need to understand the difference between them because there are different things you need to do nursing implication wise. Okay, for example, a meter dose inhaler, if you look that up, it often tells the patient to prime the device with a pump, with a spray first. I would not do that with a DPI. Okay, shake it well before you give it is appropriate for a meter dose inhaler, not necessary for a nebulizer, not necessary for a DPI. So those little things are very important that you understand. Okay, so chronic obstructive pulmonary disease, slow progressive disease, it's going to result in airflow obstruction in the airways, in the pulmonary parenchyma, or both. Okay, it's important for you to understand that it is preventable and treatable, but it is not fully reversible. So it is progressive. When we talk about treatment for COPD, our goal is to maintain respiratory function for as long as possible. 3 big causes or risk factors, I would say, of COPD. Smoking, number 1. Okay, even if you're taking care of a patient in the hospital and they've been a smoker, even if they don't have a actual diagnosis of COPD, you can bet they have some underlying lung damage. The other thing, because we've had patients with COPD that say, but I never smoked, I wasn't around smokers. The next thing I look at is occupational exposure. We talk about secondhand smoke, but also occupational exposure to things like asbestos, dust. So you think about construction workers, exposure to chemicals, perhaps inhalation of chemicals, pharmacists, your old school pharmacists where they used to do the compounding, where they, make solutions and stuff like that. Very, very high risk group for COPD because they would inhale some different things. Today's pharmacists and our pharmacy procedures are much different. When they mix things together, they're doing it with personal protective equipment, with special gear. They're doing it with ventilation hoods in their work area. So it's a much different environment, but we look at occupational exposure. And then there is a group of COPD patients that it is caused by an enzyme deficiency, specifically an alpha-1 trypsin deficiency. So just kind of understanding that. From a patho standpoint, what happens is there is an abnormal inflammatory response to any type of particles or gases. And these repeated exposures cause chronic inflammation changes. So that chronic inflammation actually damages the respiratory tract tissue. It causes scar tissue. And that scar tissue, as it builds up, causes narrowing of the airways. It's also going to cause what we call decreased elastic recoil. So decreased compliance. So the lungs will not expand and contract as easily as they did before. Okay. So this scar tissue is happening in the respiratory tract. It's also happening in the vasculature, the vessels within the lungs. So the vessels are thick, they're hypertrophied, and this is what actually creates what we call pulmonary hypertension. So increased pressures in the vessels within the lungs. And that will lead to right-sided heart failure. Long term, it will lead to right-sided heart failure. And we use the term cor pulmonale to refer to that. So in COPD, it's actually two big disorders. There's chronic bronchitis and there's emphysema. So we're going to kind of look at both of those individually, but understand that they can occur together, and both of them are under the umbrella of COPD. So chronic bronchitis, for definition of this, for true diagnosis, is cough and sputum production for at least 3 months in each of 2 consecutive years. Okay. With chronic bronchitis, that ciliary function is reduced, so that wonderful cilia that always flows, that's trying to take, particles and things that shouldn't be in your lungs back up so you can cough them out. Those cilia are not functioning well. So ciliary function is reduced, those bronchial walls thicken, the airways narrow, and then there's mucus production, so it plugs the airways. And you can see that really nicely with the picture that's on your screen. What is a normal bronchus, and how when you have somebody with chronic bronchitis, how much that airflow is limited, how much it's reduced. So the alveoli then become damaged, they could become fibrosed, and the macrophage function diminishes, which that then puts them at higher risk for respiratory infections, which is just like kicking somebody when they're down. Okay? It just kind of, is a vicious cycle. With emphysema, you have abnormal distension of air spaces beyond the terminal bronchioles. So if you're looking at the picture that's on the right side of the screen and you see the bronchioles come down and they're branching off into the alveoli. So what happens with emphysema is air gets trapped in the alveoli, and it basically just expands and it kind of blots them out. So instead of those nice little grapes, it can be just one big, enlarged, it almost reminds me of like a tree of broccoli. Okay. So what happens then, it decreases the surface area of the alveoli. So you have dead space. And what that basically means is in that dead space, there's no oxygen CO2 exchange taking place. Okay, it's just there's no diffusion there. That is going to result in lower amounts of oxygen in the blood and higher amounts of CO2 in the blood. Okay, again, because of the increased pressures in the vessels in the lungs, that's going to also result in heart failure, that cor pulmonale. So you can see, on the screen what would be normal alveoli and how they look. And then you can see how those alveoli individually get distended, or you can have then panlobar emphysema, where you can see just it's the entire lobe. So manifestations that you would see with COPD, there's 3 primary symptoms that are classic symptoms. They're going to have a chronic cough, they'll have sputum production, and they're going to be short of breath. Now, how short of breath they are really is going to depend on the severity of the COPD. In late stage or severe COPD, you're going to start seeing weight loss in these patients. And it is simply because they cannot take in adequate nutrition to support their body. They're actually expending more energy breathing and eating than they take in with their nutrition. They will often develop what we call a barrel chest. So you may have heard that before. And that refers to the diameter, anterior posterior diameter as compared to the transverse diameter of the chest. Okay. And you can see that in the picture where a normal adult, you have a 1-to-2 ratio, and when you see a barrel chest, it's a 1-to-1 ratio. Okay, and all of that results in the lungs not expanding and recoiling the way they used to before. And again, as I mentioned in a previous capture video, long term you're going to see nail clubbing because that's an indication of long term hypoxia. Again, COPD is going to be diagnosed and classified severity wise based on the results of the pulmonary function test and specifically the spirometry. So spirometry, again, we're looking at forced vital capacity, so FVC. Normal is going to be greater or equal to 70% of the predicted value based on people with similar characteristics. Anything below 70% is indicative of airflow obstruction. And I have on the screen for you just the basic staging, what we're looking at here, to try to determine do they have mild, moderate, severe, or very severe COPD. So in managing COPD, again, just like with asthma, we look at long-term maintenance control, and then we look at short-term dealing with acute exacerbations. So let's talk about maintenance, because our goal really with COPD, with asthma, is to maintain respiratory function. We want to maximize respiratory function for as long as possible. We want to prevent exacerbations. We want to keep them as functioning as possible. So for long-term maintenance control, smoking cessation is going to be critical. We promote vaccination with these patients, again, because any type of infection is going to put them at risk for an exacerbation or a flare-up. Balancing activity and rest. And that will be progressive. That will change as your patient works through the stages of COPD. Somebody in very severe end-stage COPD, they may be totally out of breath simply sitting up in the bed and trying to get to a bedside commode. So trying to balance that activity and rest. Oxygen therapy, again, we want to maintain oxygenation, but we don't want their oxygen levels too high that it suppresses their drive to breathe. We'll use inhaled medications, your long-acting bronchodilators and anticholinergics. Again, those are maintenance, but these patients may also use rescue meds as needed. They may use rescue meds like albuterol, ipratropium duonebs every single day, maybe several times a day, as part of their long-term management strategy. And then, of course, your inhaled corticosteroids. And I really want to emphasize that for long-term maintenance control, the steroids that they're receiving are inhaled corticosteroids. On the short term, if they're experiencing an acute exacerbation of COPD, we're still going to continue their maintenance therapy. That's still going to continue. They may require increased oxygen at that point. Again, we need to balance the risk of oxygen toxicity with hypoxia and hypoxemia, so it can be a delicate balance there. We're going to use short-acting bronchodilators along with their maintenance meds. At this point now, we're going to use IV or PO corticosteroids because they have an acute exacerbation, they have acute inflammation. We need to get that inflammation down. Certainly, we're going to treat them with antibiotics if we suspect that the infection is an underlying cause. Again, even though antibiotics do not work on viral infections, if we are suspecting the COPD exacerbation is because of an underlying cause of an infection, we are going to go ahead and treat them for infection. Mucolytics, expectorants, again, we're going to use that to try to help maximize expectoration of those secretions to promote airway clearance. And again, antitussives, trying to balance those in order to allow them to have adequate rest. So additional collaborative care, high Fowler's positioning, coughing, deep breathing, suctioning, huff coughing is very important. Make sure you take a look at that in your textbook because that's commonly used, particularly for exacerbations. IS and flutter valve, breathing exercises to reduce air trapping. Remember, one of the characteristics of COPD, particularly the emphysema piece, is that they have a problem with air trapping. So they cannot exhale all of the air that they took in. So things that can kind of help with that is diaphragmatic breathing. So it's controlled breathing. They're breathing from their diaphragm as opposed to the top part of their lungs, the lower part, or pursed lip breathing. Okay, and the whole idea of these is to try to slow down their expiration process to try to maximize, how much air they're getting out of their lungs. So pursed lip breathing, and you can practice this yourself. It's almost like you would be blowing bubbles. So if you have bubbles in front of you and you're blowing them, you're pursing your lips and you're extending that exhalation portion of the respiratory cycle. Certainly reducing pulmonary irritants. This is why we have the policy that you cannot be coming to clinical smelling of smoke or other strong scents because it can set off these respiratory patients. Supplemental oxygen, of course, smoking cessation. Hydration and nutrition is going to be really, really important, particularly as COPD progresses, because these patients will lose weight. And it literally will get to the point where they're so short of breath, they can barely even eat. And when they are that short of breath, when they eat, they're literally expending more energy to eat than the calories that they're taking in. So your very severe COPD patients are often very low weight. They look anorexic. They look cachectic. We had a lady that we took care of down at Jersey Shore, probably over a period of time for like 5 years off and on. She would come in with exacerbations. Before she passed, the last time we took care of her, when you looked at her, she reminded me of someone who had been in a concentration camp. She had literally lost that much weight, and she was just so cachectic. Again, medications, as we mentioned before. Pulmonary rehab is used quite frequently for patients with COPD, just simply because this is a chronic disease. When they have exacerbations, they don't stay in the hospital for very long. We kind of get them over the initial hump of that exacerbation, but they may require that long-term pulmonary rehab to try to build up their endurance again. Because this is a chronic disease involving, oxygen therapy, nebulizer equipment, that sort of thing. Case management is really important in helping to manage the overall care of these patients on a long-term basis and really assess and provide for the home needs.